Okay, so this is an in-service prepared on April 19th, 2011 for a research project that's hopefully going to start in May 2011 and go on through September 2011. And the title of this research project is Sterile Technique Training for Anesthesia Practitioners, Simulation-Based Education versus Didactic Teaching Sessions. My name is Amy Fraser. I'm the principal investigator for this study, and I'm going to tell you a little bit about what we're going to do and what we're going to ask obstetric nurses to do to help us get this study done. So first, I just want to cover what the point of this research is. That is it possible to measure behavior in the simulator as an alternative to observing behavior in the clinical environment? So what I mean by this is our current way of teaching residents is all about see one, do one, teach one. And it's all done in the clinical environment, and it's all done on patients. And we all know that what happens as a result of this teaching strategy is that harm comes to patients when inexperienced practitioners learn on them. So what education researchers are thinking about now is, can we teach people in the simulator? And if we're going to teach people in this simulator, we have to be able to figure out if they're progressing or not. So we have to be able to assess them in the simulator. And this might lead to important benefits not only in patient safety, but in terms of acceleration of education. That is, by the end of their first year in residency, a PGY1 will have done about 20 epidurals. But if we send them to the simulator, they can do 20 epidurals in one day. So they might be more competent sooner and safer all around. So then we get to our project, which is teaching sterile technique to residents. And we need to know what is the best way to teach sterile technique to residents. The way we do it now, which is at the bedside, involving a live patient most often. Or should we give them a formal curriculum? Or should we give them a curriculum that maybe involves simulation? And what we're looking at here is what is most effective and also what is most cost effective, because we know that, for example, mistakes on patients are very costly, but also simulation is very costly. So we're going to look at that. There's going to be two phases of this study, and the one I want to concentrate on today is phase 1. So for phase 1 of this study, we're mostly going to look at the assessment question. That is, when we look at what a resident does in the simulator, is it the same as what they do in the clinical environment? And so can we take, say, a performance in the simulator and say, okay, that makes you safe in the clinical environment too. So what we're going to do is have 30 residents and 30 obstetric patients who are presenting for labor and delivery. And we're going to videotape these residents doing 2 epidural insertions. The first epidural insertion is going to be with the epidural mannequin. I don't know if you guys have seen one of these, but it looks like a torso, essentially everything from the shoulders up and the hips down missing. So it's strictly for putting a needle in more or less a back. And we're going to grade their sterile technique when they insert the epidural catheter using a checklist that was developed already by researchers at the University of Toronto. So there's going to be 15 points of sterility that we're going to be looking at. The second epidural is going to be done in a patient, and we're going to do the same thing. Grade their technique using a checklist. And as I've said, we're hoping to start this in May 2011. In phase 2, that's when we're going to do the education part. So it's going to be the same 30 residents, and we need another 60 patients. And what we're going to do is teach residents what we like to call best practices sterile technique. The same group in Toronto that developed the 15-point checklist has also developed a teaching video for sterile technique, specifically as it applies to epidural insertion. So we're going to split the residents into 2 groups. One group we're going to teach with the epidural simulator, and one group we're going to teach without the epidural simulator. And then once they've been taught, we're going to videotape 2 more epidural insertions in labor and delivery, about 3 months apart, to see whether A, they learned anything, and B, if they learned anything, it sticks. So I've anticipated some questions that I thought I would get when I was giving this in-service, and I'm going to try and answer them to the best of my ability. So question number 1, why are you doing this in parturients? Well, what we need for this study is a stable source of more or less identical epidural insertions. And where we get that in this hospital is in labor and delivery. It's also the, I guess, numerically highest source of epidurals that we deal with. We do epidurals down in the main operating room, but they're fewer and further between than they are for laboring women. And so this leads us naturally to the question, is this ethically okay to, number 1, do a research study in pregnant women, number 2, videotape them for an epidural insertion, and I guess number 3, get consent in pregnant women. So there is a long history of, I guess, ethical research that's done in pregnant women, and we do have to make sure that we meet a few more stringent requirements before we can do it. But yes, it is ethically okay, and yes, we do have ethics approval from the Ottawa Hospital Research Ethics Board. This group in Toronto is the group who we've modeled this study after, because they've already done this type of videotaping in pregnant laboring women for epidural insertion and sterile technique. So based on that previous experience and based on our ethics approval, we have to say, yes, this is ethically okay. Another big question on everyone's mind is, will this delay epidural starts? We think no, it will not, and in fact it may improve the time between request for epidural and epidural start. What we're going to do is we're going to have residents down in the main operating room having their normal day, or perhaps a resident assigned up here to labor and delivery who will be eligible to have their epidural start videotaped. When you need an epidural started, you page the resident, and our research assistant will also come along and set up the camera. The camera frame will only include the sterile tray, the resident's hands, and the lower back of the patient. So it will exclude all identifying details of both the resident and the patient. If we're asking someone to come up from the main OR, we'll have hopefully a few people so that we can pick someone who can come right away. And that way, you're not going to have some of the typical delaying factors for epidurals, like, the staff up here is stuck in a C-section and that epidural will get done when we're done, like in maybe 20 minutes. So we're definitely not going to violate existing patient care standards for this study. That is, if we're going to go over the 30-minute mark for whatever reason, we pull the plug and we start again with a new patient. We don't make anybody wait for an epidural for the purposes of this study. The fourth question, what will L&D folks have to do? I've got a couple slides about that, so I'll defer that for the moment. Number 5, I think is an important point. As a nurse, can I intervene in cases where I think sterile technique is obviously substandard? Which is important at all phases of this study. If you see, for example, a break in sterile technique, yes, you can alert the resident that there has been a break in sterile technique if they have not noticed it, or you think something needs to be done about it. I'll have more to say about this for phase 2 of the study, but there's going to be a separate in-service for that. Last question. We're going to teach the residents sterile technique with a video, and I know some of the nursing managers have expressed interest in having the sterile technique video. The answer is yes, but later. What I don't want is for nurses who are well-versed in the sterile technique video to correct the technique of residents who have not yet had the training, because the sterile technique in the video is a little bit different from what we do now. So when the residents have all had their training, we will release the video for your use. I thought it might be important to know the inclusion and exclusion criteria, because obviously for compassionate and ethical reasons, not every pregnant woman who walks through the door is a reasonable candidate for this study. we'd like to have included in the study parturients who are over the age of 18, and we'd like to see them if they're presenting to triage for labor or induction, or if there's, I guess, some busyness in triage, if they're admitted in early labor. And we'd like to see them between the hours of 8 a.m. and 4 p.m. on selected weekdays. And this is based on the availability of our research assistant, which I'll get into a bit more in a coming slide. Obviously, there's some people who need to be excluded. If the fetus is premature, small, ill, or there's been an intrauterine fetal death, that's an exclusion criteria. If the mother has significant systemic disease, a coagulation problem, or has had back surgery, especially back surgery with instrumentation, we're going to exclude that. We definitely don't want to mess around with sick mums or anybody in whom the epidural is going to be predicted to be difficult. And again, along the same reasoning, we're going to exclude people with a BMI greater than 45, and we're going to exclude people in advanced labor, mostly because getting proper consent becomes difficult if people are in a lot of pain. We're also going to exclude people who speak neither English nor French because we just don't have the translation services to deal with that. So what are we going to ask nurses to do? Hopefully you're going to think this is not too much. So when patients are going to present to triage for labor or induction, we are going to ask the nurses who are working in triage to ask patients if they're planning to have an epidural or considering an epidural. If they say yes, you will then tell them that we have a research study in progress and ask the patient if they would consider speaking to our research assistant. Her name's Julie Gatalia. And then page the dedicated pager between 8 a.m. and 4 p.m. on selected weekdays, which are probably going to be Thursdays. Up will come our research assistant and chat with them. For phase 2, it's going to be very much the same as phase 1. We're going to recruit in triage much the same way. Once the residents have been trained in the new sterile technique, they may ask you to help in different ways during epidural starts to deal with their sterile tray. Because as I've said before, the new sterile technique is a bit different. This is going to be a bit of an awkward phase because we're not going to release the video to nurses at this point. So you may not know why they're asking you to do what they're asking you to do. However, we hope that you can be accommodating to some changes in the way we do sterile technique in order for us to improve the way we do stuff around here. So what are we going to do? Julie Gatalia, the research assistant, is going to come to morning rounds on data collection days, as I said, Thursdays and maybe some Wednesdays, to remind everybody and just refresh them like, hey, we're here today and we're looking to collect some data. She's going to operate the camera. And we're going to obviously in-service people who are involved for each phase. Plus we're going to leave a video recording, this one, for review. We're going to be available to address questions or concerns at each phase, and there's going to be information available with my contact information in it, etc. So in summary, what we're hoping to do is make sterile technique and epidural starts better and safer for everyone. So that's patients, that's nurses, and that's residents too. We're hoping to have residents who are better trained in technical procedures before they ever set foot on labor and delivery. So better at sterile technique too, but, what we're learning here is hopefully ways to teach them technical procedures like epidural starts and sterile technique before they touch patients. And we're hoping to have your support and help for this project. Thank you.